Good day, all, and welcome to the Teledyne Pulse podcast, your rural health matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Welcome to the Teledyne Pulse. This is part one of a two-part series on real-world success with telehospitalists in the rural environment. And we're coming to you from the Missouri Hospital Association today. Shane, who do we have with us today?
Well, Andy, excited to be here for several reasons. One, it's a blast to be able to record this in person, Chris, at the Missouri Hospital Association meeting, and to have you with us is absolute. We're just blessed to have you with us. So I really appreciate you taking time out of your day to spend with us here at the Hospital Association. But I am excited to introduce Chris Wyatt as our podcast member for our first session, or I should say part one of our Success in Hospitalist Medicine in Rural Environments. And Chris, I think we'd start off with maybe a little bit of an introduction about yourself and a little bit about your facility and a little bit about what you do. How about you hit us up with that?
Sounds great. Well, thank you for having me. I've been a customer with Teledyne, should I say, for 5 years now, and started at Cox Health at Barton County, which is a 25-bed critical access hospital. When I started 5 years ago, they were losing 9% profit margin every year. Quality was down. The only thing that was going even remotely well was the patient satisfaction. But when you have a census of 2 to 3, it's easy to give great patient satisfaction.
A lot of support there.
Yes.
Yeah, for sure. For sure. Well, that's great. I know you came out of North Dakota originally, and maybe a little bit about that experience.
Yes, originally from Missouri, but my career's taken me between St. Louis, Washington, D.C., and then my first CEO opportunity was in a rural community in North Dakota, and really hard to get physicians to that area, and especially in rural America in general.
Oh, yeah, absolutely.
That's what drew me to Cox Health. It was another opportunity to grow and show that we could be successful in rural America, as we were able to in North Dakota, turning that hospital around.
Yeah, that's awesome. I know you've had a lot of success on that front, which is why I was excited to get involved with Cox Health right out of the gate several years ago. And I think it was interesting because when we first got engaged with your health system, you weren't there. And we met with the executive administration and the VP of outreach at the time. It might not have been Max's exact title at the time, but I'm not sure what it was. But nonetheless, we got hooked up and met, in fact, was at Barton County. And long story short, they thought that our telehospitalist model was gonna be helpful for their organization. And Dr. Sturgill was one of the leads on helping to push that through, who will be our guest joining us for our part 2 session on this. But as we talked through the process, they agreed to move forward with it. And I was notified about a week later, said, "Hey, Shane, just so you know, we have a new CEO that we hired. He's going to start on this day. And so we'll just table any further discussions on the launch process until he starts." And so I remember this just vividly clear. I called Chris and I said, "Hey, Chris, we're going to be in town on Tuesday or Wednesday, whatever week it was. Are you available?" He goes, "Well, it's going to be my second day on the job, so my schedule's pretty clear that day. So knock yourself out." And so maybe describe what it was like starting at a hospital, and on day one, say, "Chris, welcome to Barton County. Here's your new beautiful facility," which incidentally, it is a beautiful facility. And oh, by the way, you're starting a telehospitalist program. Tomorrow is the launch process began anyway. Can you kind of describe what your initial reaction was when you found that out?
Well, luckily, I had worked with telemedicine in the past at the prior hospital, but was only in the ER. And I've got to say, between working with Bryan Health and Teledyne compared to the other one, it's night and day difference. I had some good experiences with the others, but there was still a big gap. So that really helped coming in, but it was still the shock of, all right, in the prior location, I had 3 years to introduce them to this idea. Here, the decision was made, and it's like, "Chris, get your physicians on board." That in itself is always a challenge, and showing them the benefit whenever the idea is, well, we're rural America, we're an older population, no one's gonna really buy into this.
Right. And, that's interesting. after our first visit there, and we said one of the things we typically do is some sort of forum strategy and introduction to the community. We firmly believe that's a big piece of this. And so I remember getting invited to join you at the community forum that we did off campus, and which is about 30 to 40 days after the launch process started. And I remember after that meeting, you got up and you did your presentation, which you did a great job, by the way, doing
Thank
that.
you.
So then I gave a little blurb on the virtual strategy and hospitalist model that we're about to launch. And after that meeting was over, you kind of grabbed my shoulder and you said, Shane, hey man, I just want to let you know, I've been talking with a lot of the primary care docs here, and man, they don't think we need this. We're keeping all of our patients. And I said, well, Chris, I got to tell you, based on the numbers, I don't know if I agree with that. I think we could do some good things here. So, let's be patient. What was your takeaway from those initial discussions that you're hearing from the med staff? Because that's kind of a common thing, right? That CEOs are going to hear from their local medical staffs who may be somewhat apprehensive to bring in a telehospitalist model.
Well, you hit the nail on the head right there. Most physicians don't see what is outside their purview, and that's not to be condescending, but physicians are great at taking care of acute issues. CEOs and hospital administrators are there to look at the business aspect. What is the leakage? And we also know that you get on the wrong side of your physicians, that's a quick way to lose your job.
Oh yeah, yeah, for sure.
So
for sure.
Right out of the gate after this, getting a lot of pushback. So that was definitely something that was on the back of my mind of, all right, do I need to try to preserve a job, or do we do what's best for the community? A leader needs to take people where they need to go, not necessarily where they want to go, but you have to lead with that carrot more than the stick. So it was that dynamic of trying to get back and say, all right, I need you to partner with me. Let's get on board with the physicians, hear their concerns. And that's why I love that you and your team are coming in and talking one-on-one with the physicians, saying, hey, what are your concerns? Let me show you real case studies. Here's some other physicians at other facilities that are experiencing the same apprehension that you have at your campus. And sure enough, the leakage was there.
Yeah.
As soon as you said, I don't really know, and then start bringing in Dr. Sturgill, and that guy's a go-getter. You find that one great physician
absolutely
that really buys into a vision.
Yeah.
That's all it takes.
It is.
And he was able to show, yes, here's how many millions of dollars that we're shipping out to a tertiary center that we don't need, but it's because in the evening time, we don't have a physician on staff, or we have a clinic physician that's trying to cover the hospitalist and he's sleeping. The nurses don't want to call him in the middle of the night. And then what ends up happening? It's just easier for me not to deal with it. I'm just going to send them down to our competition.
Right. Well, absolutely. That, and kudos to all. I'm always very empathetic for all of our rural physicians in rural America. They're busy, in many cases overworked, and very busy clinics, in some cases covering the ED and then doing inpatient work. And it's just a busy practice in most cases. And I think I can't agree more. You hit the nail on the head with Dr. Sturgill. If you can find one physician champion to at least go down the road with you, go down this path with you, it's a big deal. And as I mentioned, Dr. Sturgill, who will be on our part 2 of the podcast, was definitely instrumental in helping to get the program off the ground. So I'm excited to bring him into the mix here for part 2 of the series. So can maybe, about 6 months into the program, I know that you and I talked frequently after the start of the program, particularly as it was somewhat fragilely received with some of the physician ranks out of the gate. But what were you hearing from the patients and the nursing staff once the program was started? And can you maybe offer some feedback on what were the initial actions? Because I know you were going in this, holy, I've been here 2 days. They throw this in my face. I'm starting a telehospitalist program. And my primary care base says we don't need it. So that's a tough predicament, right? Mm-hmm. So you're a little apprehensive. You're going, well, hopefully this works. So you got your nose to the ground on this one. You're making sure everything's going perfect. What were you hearing initially?
Well, that was the big thing there. Is changing the mindset of where we had clinicians in the rural health clinics also doing hospitalist work, and we were changing the entire model. It was saying we are going to have sole hospitalists that are covering during the day, Monday through Sunday. And then in the evening, we're going to have this program going on as well. So there was a little bit of apprehension there as well of, well, how does this affect me? What's my pay scale going to be? And, we were working through those dynamics. So the nurses were kind of buying in a little bit into that, not just nurses, but I'd say everyone into that apprehension. So it was a lot of boots on the ground. But the best part is as they saw their patients coming in, and the doctor will pop up there, and I'll throw one guy out there, Dr. Studley. The older female patients really love seeing him pop up there because he's sat there, nice young man sitting there talking to him and walking through step by step. And they're like, what, you can zoom in that close and see what's going on? Oh yeah. On top of that, listen, stethoscope, and he can sit there, look, I can rewind, amplify, and I can hear more with this with the computer technology than I could if I was there in person, because I can't rewind your heart.
Yeah, right.
Here I can, and I can do that. And the patients were just amazed by that. So as the patients start buying into it, then the nurses, they're like, you know what, doctor, I know that you're not, but listen to what our patients are saying. And that started slowly changing that mindset. And then the big part was the ER doctors,
right?
How smooth it was to get them admitted in the middle of the night, where they were having to say, all right, well, now I've got to call the tertiary center. I've got to try to get an ambulance, whatever we need to. And then you have an ambulance district that's not connected,
right?
That doesn't want to make the runs in the middle of the night. And then they're boarded in our ER. So that part right there, they were able to put more pressure on the other physicians saying, no, this is good for us.
Right.
So then you get that collaboration and that discussion between physicians that really made my job a lot easier. You get one group that buys into it, then they're the ones that are leading that message.
Absolutely. And I think, for us, in terms of any type of hospitalist program, and incidentally, hospitalist programs aren't synonymous with each other in terms of how people define hospitalist programs, but in the comprehensive models, we definitely find that emphasis on nursing training and ease of use for the nursing staff is really critical as part of these programs. So nursing satisfaction is a big piece of this. And so you have some apprehensive physicians on the one hand, and then if you have some apprehensive nurses, it's really set up to get sideways pretty fast, right?
Correct.
And so subsequently, really jumping into that position with both feet, and things have to go maybe not perfect, but they have to be close to perfect in order because otherwise, boy, those two apprehensions really, they start to, it just snowballs, and before you know it, you have a wildfire on both sides, and things get out of control. So the nursing staff satisfaction, you would say, has been relatively high, and the experience, at least one of the things that we look at is lowering the threshold for a nurse to call in the middle of the night. You said earlier that a lot of times in nursing, and me as a nurse are very familiar with this, where you're sort of resisting calling a provider in the middle of the night because you don't want to wake them up, because, as I mentioned before, they're so busy. And one of the things we like to do is reduce that threshold for a nurse to call, pick up the phone, call, get an issue addressed right then, right there, now, as opposed to wait till 7 a.m. where the rounds start and that patient's been waiting 6 hours, for an issue. Overall, the nursing perception, what are you hearing from the nurses overall?
100% buy into it, and it really took that first 3 to 6 months in there, as we were talking about that, where it finally started turning over, because it was the idea of, well, now we have a higher census, we're understaffed for that. And it's like, well, wait a minute, you had 2 to 3 and now we've jumped up to 5 and you're overwhelmed. But that's not to put down anyone. You get used to what's there. So you had that apprehension there as well of like, well, this is an extra step. Now I've got to actually call a doctor. But then they realized, well, wait a minute, we've already had all the training. This is easy. I just go in there, push a button, they're on in 60 seconds. They know our system. They learn Cerner. I know they work with Epic as well and all the others. So they didn't have to do anything. The physician was doing all the charting, and they said, wow, this is a lot easier than I thought it was. I'm just sitting here watching a patient while they're sleeping.
Yeah, right. Well, it's big. It's big. We've seen that in a lot of instances where nursing can really control a lot of those factors at night. Is in terms of transfer analysis, one of the things we look at is several variables that raise or lower the threshold for a patient to be transferred, and nursing competency, experience, their overall perception of the program is an absolute factor in decisions to transfer. So let's move maybe a little bit more off of the clinical aspect and move more to the CEO aspect in terms of the business side of the equation. So when we were involved in that program, as I recall, your census was somewhere around the neighborhood of 2.5 to 3 or thereabouts.
Correct.
And can you maybe describe what you've seen over the last couple of years since the program's been installed, which is coming on, I believe, almost 4 years now?
Yeah.
Or closer, is it 3?
5.
Almost 5 years?
Yes.
Has it been that long? Gosh, time just flies, you know?
I know, right?
It's just, man, 5 years, holy moly. So 5 years. Can you maybe describe where you're at now in terms of average daily census and what you're seeing in terms of patient days and just downstream impact that the program's had on the facility?
Well, I alluded to it a little bit earlier, but our census back 5-6 years ago, Cox Health took over in January 2018, and I started January 2019. And our census was 2.5 to 3.
Mm-hmm.
But the worst part about it was the same thing rural America is experiencing all across. It's negative profit margins, losing 9% every year, and they had been for 7-8 years before Cox Health took over, and then even the year after they got in there, because it was building that program, getting people in that mindset. And now we're at the point where we just finished our second year. Last fiscal year, we ended with an 8% profit margin.
Mm-hmm.
And this year we have a 16.2%. We just finished our fiscal year for 2023.
Oh, congratulations. That's awesome.
That's
Yeah.
great.
Especially in today's environment.
Yes. Yeah. And that's with rising prices. And on top of it, the biggest thing is recruiting.
Mm-hmm.
We could not get staff or anything. It was travelers. And this was even before COVID hit. No one wanted to come to rural America. And we have 9 hospitals within a 45-minute drive of us. So
Right.
the competition's really big.
Yeah.
But now that they know that they've got that support structure, we've been fully staffed to nurses now for a year and a half.
Mm-hmm.
And our turnover is less than 8%.
Mm-hmm.
And it's just that level of confidence where the nurses know that they're supported, with a program like this, and the evenings really helped with that.
Yeah.
Then as we start looking at the quality measures, those have increased, because the things that you don't know what you don't know, you get outside eyes on that and saying, hey, look at your CLAPSI, look at your CAUTIs. Hey, here's a different way. And as you and I discussed yesterday,
Yeah.
Why are you even putting that in the first place? Versus, well, hand hygiene, make sure the sites are clean. Well, no, let's look at this a different way. And that outside vision of this is what really helped us on that. And then as we start looking at our community perception of the hospital, it even took them a while, because they were sitting there. I was like, well, that's the Band-Aid shop. If I go in there, all they're going to do is ship me out.
Mm-hmm.
And then even our doctors had that mindset.
Right.
So Dr. Sturgill really pushed it on and said, no, now we have this hospitalist program. We've hired a hospitalist during the day. We aren't going to ship them out. Let's look at every single thing that's going out our doors and ask ourselves, could we have kept that? Let's follow up with the patient and see what they ended up doing. And now patients know that when they come here, if we can keep them, we are going to keep them. We're keeping things that we never even used to keep because of that confidence with, Teledyne and those physicians giving us the feedback of, all right, do you have these capabilities? If you don't, here's what you need, and let's get the training in there. And so it's that collaborative effort to really get it in there, because a rising tide lifts all ships. And that's what we found in this partnership of, we want both of us to succeed. It's not just one of us.
Well, that's a game changer for your community too.
It is.
Yeah. It's really, our mission is really, we're so passionate about rural health and keeping rural health viable, relevant in the game. Right.
Mm-hmm.
And so all too often, I think the rural hospitals just sort of this mindset where, inpatient volumes are down, everything's going outpatient. And we find, not in 100% of the cases, but in most cases, there's absolutely patients leaving the facility that could be. I'm going to press on one of the issues you brought up too, in terms of the community perception. And this was something that over the years hadn't really picked up on. And this was one of the first facilities when we started really digging into the metrics that I found astonishing. And that was the increase in the emergency department volumes from where we started to where we are today. And it's really been sustained at that level. There hasn't been any new industry move to town. No, the population hasn't doubled, nothing like that. But maybe speak a little bit about the emergency departments and sort of I guess you could qualify as somewhat of a hypothesis, but really the community perception and your point of the Band-Aid station. And when you have such an inordinate amount of competition within an hour for sure, that, and as an old paramedic eons ago, loading a patient in the back of an ambulance and bouncing them down the road for 45 minutes to an hour is not an attractive proposition to patients. So what were they doing? They just weren't coming to your facility at all. So maybe could you describe, and I know Dr. Sturgill will touch a bit on this too in part 2, but what's been the impact in the community perception and maybe the ED volume increase that you've seen?
Definitely. As I alluded to, the big part of that was the ambulance districts in the area as well. They would bypass us right away.
Yeah.
Because said, well, why am I going to stop there if I know I'm just going to have to get back up in a couple hours and then drive them another 45 minutes down to a tertiary?
Been done that, by the way.
Yes.
Just saying.
Yeah, and I don't blame them. You know, these individuals work so hard to take care of these patients, and then why do they want to spend 4 hours wasted whenever they could have just taken 2-hour drive? So that's been a big impact on it. And then the patients, we also used to get, well, the patients are requesting to go to this facility or that facility. So how do you change that perception? Well, by getting them in the door and showing them that great patient care, by showing them, hey, we have top quality physicians. And it truly is. It's a rolling ball. Once it gets going, it's hard to stop it. Then it's easy to recruit other physicians that are high quality wanting to come in there. But our ER volume when I started was just a little over 6,000 visits a year. Mm-hmm. Now we're upwards of 8,500. Mm-hmm. So almost a 38% increase, doing the math in my head right there. It's been a series of things. One, that confidence from the ER doctors knowing that I can admit them and they're going to stay, which I didn't hit on this, but our inpatient volume, where our census was average 2.5, now our average census is 13.
Right.
And, we routinely are going to jump up to 19, 20 patients, sometimes 21. Yep. And when it drops back down to 9, our staff is like, man, I'm bored. What do we do?
We're a little different than when they had 2.5, right?
Yes. And they jump up to 5 and everyone felt like, man, we're overwhelmed. We can't do this. But you get used to that. So by the patients being able to come in and having that confidence of admitting them into the hospital and then being able to stay here, that allowed us to focus on other things. And I said, hey, Dr. Sturgill, what are some programs that we could be looking at that will allow us to continue to grow? And he said, you know what? There's not a stroke center within an hour drive of us.
Right.
You look at 50 minutes to the tertiary hospital, but by the time they park, get in, it's over an hour. And I said, well, what do we need to do? That freed up so much more of his time to start saying, all right, here's what we need to do, become a stroke program. Yep. Look at Teledyne, Bryan Health, and say, what could you offer from the neuro side to help us get there? And, we ended up internalizing it, but the services were there. And whenever we looked at, wow, you guys are doing this, where can we pull from internal resources as well to get it? But that collaboration of still on the hospital side saying, hey, make sure your neurologists are looking at this because this is what ours are telling us. So it wasn't an added fee that you charge us just to give us that input. It was, hey, this is a partnership that brings in more patients that we can take care of. So we were able to get that stroke certification, the only level 3 stroke center within 50-mile radius of us. And then all the ambulances then had to come to us. We politely went to them and said, hey, if the care is appropriate, by law, if care is appropriate, we are the nearest stroke center. And so then that actually starts bringing in people from the other counties that would have to drive past us down into the larger metropolitan. They stopped and the patient's like, wow, this is amazing. And then inevitably on some of the patients, we end up having to transfer them because it's outside of our care. But we keep 90% of those. Right. But then they come back, they said, I went to that other hospital. I will never go back there again. I'm demanding to come here. And then they tell their friends.
You're right.
And so it's just that,
especially in smaller communities, that word of mouth is huge.
Yes.
It's just huge. And the stroke neuro programs have been a raging success in all the hospitals that have been deployed. And in fact, we're keeping 72% of all stroke neuro patients in-house in critical access hospitals, including those post-TPA patients. So they've been a huge success. And in terms of the bottom line, I think for for your facility, when we got involved with a census of 2.5 and now a census of 13 and ED volumes increasing 30 to 35, 40%, it's a dramatic impact for the community. And our position has always been a rural community without a strong rural hospital is a struggling community.
Yes.
And if the hospital goes away, we've just seen such devastating effects. And I can't emphasize enough. And you mentioned this earlier when you said it's got to be a win-win. You know, we can't be a financial boat anchor to a facility who's already struggling financially, right? Mm-hmm. So it has to be a win-win in these situations. So I think that the community perception is big. And I also believe, you know, you mentioned that the ambulance engagement is a big part. So it's several factors in these programs that ultimately lead to success. And definitely one of those is community engagement and continued engagement. With, for example, on the stroke neuro side, engaging the EMS agencies as part of the rollout of those programs is a huge factor that highly recommend anytime you're getting into, whether it's hospitalist or stroke neuro or any other program for that matter, getting involved with the EMS agencies and educating them on what you do at the facility, particularly if you got facilities that are within X amount of miles of you that are causing leakage or outmigration to those areas. And so the community grassroots effort's important, as well as the EMS agency. So I can't agree with that more.
Well, and to add on to that, being able to tell our story, you know, there's so many great examples where patients had good interactions at the hospital with our telemedicine program. And, you know, you get a great marketer, and we have a great social media marketer that she goes out there and she's walking around, you know, and one of the physicians are on the computer, she's doing a story on them, asking them, hey, what do you think about that? And putting it out on social media. That's what people are reacting to. Right. They aren't going to know that you have the latest 128 slice CT and can do perfusion studies. What they're going to know is that empathy, that story. And it makes it so easy whenever you have a great partnership in that to find those stories and tell them.
Yeah. Oh, I can't agree more. And again, it only it just takes a couple of folks really in the community to have a great experience. And the great experience starts with success in building the program. It starts with leadership at the local level, and it starts with programs that are set up soundly from a technical perspective, so there's not a lot of hiccups. The technology works. The doctors can complete a comprehensive examination of the patient, but it's ultimately the physicians you're putting on the screen, right?
Yes.
You know, my philosophy has always been jerks on a screen are going to equal jerk results. So unfortunately, and then I get calls from Chris going, hey, what's going on with this? So thankfully, I've never had one of those calls from you. But it's really, you know, the physician teams who've just been so blessed with some amazing physicians who really are passionate about rural healthcare and helping rural healthcare and keeping patients closer to home, which is what we're all about.
Yeah, and in 5 years that we've had it, we haven't had a single physician where it's like, hey, by the way, this physician's leaving. Here's a new one to train and get. We've had the exact same physicians for the entire 5 years. You know, I think we have a rotation of 3 that come through there, and it's great.
Yeah.
Well, it's great because the docs and the nurses, they build a relationship.
Yes.
And nurses know, okay, Dr. Studley's on tonight. I know, you know, what he needs from me when I call him, those kinds of things. It's a great relationship.
Yes. And the fact that they can hit the button and within 60 seconds, he's there.
Yep.
And, you know, rarely there are times where he's like, all right, I'm on another call, and then it would roll over to someone else. Mm-hmm. And that's amazing to be able to have that.
Yeah. Well, that's great, and I really appreciate your time to spend with us today, and I just some parting thoughts from your perspective in terms of again of all the hospitals. You know, we're in over 100 facilities and a lot of different hospitalist programs as well as part of that across the 50 different service lines. But you know, what type of advice would you have for a rural CEO that's contemplating, golly, what do I do about I'm just hemorrhaging transfers. I'm hemorrhaging patients out of my ER or not coming to my ER. I know I'm missing out on volume, but I have these challenges with either the nursing staff or the med staff or the board. What type of advice would you have for a CEO that's faced with some of those barriers or challenges?
You know, it's a deep question. not to be ambiguous about it, but I'd say setting a culture of excellence from the get-go. Being excellent for your patients is being able to figure out what you can provide safely and at high quality in your community. Letting the staff know that, yes, you may not completely be on board with this, but we're going to talk about it. But is this a culture of excellence by saying that we're not going to do anything, that we're going to do the status quo? Is it a culture of excellence to say, well, all hospitals are losing money or barely making money? No, you can't have that. You got to say, all right, what are the small things that we need to do to block and tackle? And being able to keep patients in your hospitals, one of those key components. And unless you have a margin, you don't have a mission. That is the sad reality. And you can't continue to provide back into your community all of the care that they need, even the care that you're giving for charity. You've got to be able to do that for the community. And, I just want to brag on our hospital. 5-6 years ago, we were on that list nationally of hospitals in the red for imminent closure.
Yeah.
And now, like I said, past 2 years, amazing profit margins, over 16% this year, second year in a row, top 20 quality hospital. Patient satisfaction, we're in the top 5% according to Becker's Hospital Review. Yep. And then, our employee satisfaction, physician satisfaction, I truly believe it ties into this telemedicine program where they see that we're being innovative and that we care about them because it makes their workload less. We're in the top 10% using Gallagher. Right. So all those things can happen, but it is a dedication to excellence of saying we are going to be the best. Let's not look at what we don't have. What are the resources out there like Teledyne, Bryan Health that can really help us?
Yeah. No, that's spectacular. I know one of the questions we often get, particularly for hospitals that have never started a program like this, or, we've went into a lot of hospitals that have had a failed program of various types that are extremely apprehensive to try another one, right?
Yes.
But one of the questions we often get is related to quality and this fear of a lower quality of care being delivered virtually versus in-person care. And I know you've mentioned this a couple of times related to your quality scores and patient satisfaction, but could you just let's press just a little bit more into that in terms of what are you seeing for patient satisfaction from the start of the program? And I know you had really good quality scores before, right?
No, we had really good patient satisfaction scores.
Or patient satisfaction scores, that's right.
Yes.
And tell me the progression. So a hospital that maybe has perfect satisfaction or perfect quality scores, but maybe their volumes are extremely low. One of the concerns would be, gosh, I don't want to tank those scores.
Yes.
Or maybe the quality scores or satisfaction scores are low. Gosh, I don't want them to go lower
right.
by doing virtual. What kind of response would you have on that based on what you've seen?
From a patient satisfaction standpoint, we have stayed right there where we need to be, at 5-star. And whenever I was there, that was the big thing for them.
Yeah.
So whenever you bring in a telemedicine program, that's going to be your fear. Well, the patients aren't going to like this.
Right.
The opposite. In 5 years, I've only had one partial complaint from a woman in her 90s just saying, I can't hear him very well.
Yeah.
But it wasn't, man, never bring that in here again. I can't hear that person. Well,
sure.
Yeah, you're 90. We need to turn your hearing aids up.
I need to turn my hearing aids up sometimes.
But from a quality standpoint, our quality was non-existent because the volumes weren't there. And if you're not doing it, there's nothing to measure.
Really measure. Yeah. Right.
But as we've seen these volumes grow, the quality has been going with it because we are able to get that feedback, both from our internal expertise, but then outside physicians sitting there saying, hey, I'm noticing that this is happening a lot. What are your thoughts on this right here? Hey, bedside falls, as we hit on, CLAPSIs, sepsis, CODIs. Those are the things that we really have been keeping an eye on. And it's that partnership with the physicians when they're coming in and saying, I probably don't need to prescribe that antibiotic. Well, why not, doctor? Well, let's make sure that we're doing a panel to make sure we're giving them the correct one, or, we're overprescribing it.
Yeah.
Those are the things that as hospital administrators, we don't normally think about because the majority of us haven't worked in the clinical space.
Right. And when we tie in the ID antimicrobial stewardship programs that tie in with and oftentimes the hospitalist programs, those types of things and campaigns around those things are extremely powerful. And as you mentioned, oftentimes overlooked. So that's another topic for another podcast, I'm thinking. But at any rate, Really appreciate your time. I know you're a busy guy, and I really appreciate you taking some time to spend with us and share your story, because it's an amazing one. And I'm hopeful that this story will resonate with some other hospitals, encourage them to take the leap and get innovative on this front and be successful right along with you. So appreciate your time.
I'm happy to do it. You know, after, as you said, working with another vendor at another place, it's been night and day difference working with your organization, and I sell it to everyone I can.
Well, we appreciate that.
Yeah, well, I appreciate that, but the proof's in the pudding, right? The proof's in the
Yep.
details. So don't take my word for it. Take Chris's word, and more importantly, take Chris's results. That's at the end of the day, we're here for really positive results in the rural communities, and we're just blessed to have you as a partner, and blessed that the program has worked in such an exceedingly great way for you down in Lamar. So again, can't thank you enough for joining, and looking forward to having your co-partner in Dr. Sturgill with us in part 2 to get more of the physician aspect. Because again, he was right there at the beginning too, in terms of helping to push the other administration side, saying, I think this program could help. I could be wrong, but I think this could help. But he's a fascinating guy. I think he's going to be a great guest to join us on our part 2.
Definitely.
Yep, sounds good.
Thank
Thanks,
you.
Chris.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired, or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGM health.com. For more information or general inquiries, please visit teledynehealth.com.